Hello, good evening everyone. My name is Dr. Afzal and today I'll be talking about the ST elevation MI. This discussion would be in two parts. Part 1 will be about the presentation and diagnosis of the ST elevation MI, and part 2 would comprise about the management of the ST elevation MI. And I hope this video will help some of the people to have a little bit better idea of diagnosing and managing the ST elevation MI in a timely fashion. Today we will be having a brief discussion about the ST elevation MI. ST elevation MI is a very much important part of the acute coronary syndrome, and this, as we know, that acute coronary syndrome comprises three components. One is unstable angina, one is non-ST elevation MI, and the last one is ST elevation MI. Stable angina is not included in the list of the acute coronary syndrome. Uh, Unstable angina and non-ST elevation MI and ST elevation MI, they have one thing in common, that is the reduction of blood supply to the muscle of the heart. But in cases of the non-ST elevation MI and ST elevation MI, there is damage to the cardiac muscles. In case of the ST elevation MI, if effective measures are taken up very immediately, then that damage can be prevented. So ST elevation MI is another form of the myocardial infarction, where you see that there is not only the reduction in the blood supply to the muscle of the heart, but there can be damage to the cardiac muscles if effective measures are not taken promptly. In majority of the cases of the ST elevation MI, the main culprit is the atherosclerosis. That is the process of formation of a thrombus in the coronary arteries. And there are certain risk factors involved in the formation of the atheroma in the coronary arteries. There are two types of the risk factors: non-modifiable and modifiable. Non-modifiable are the one which cannot be changed no matter what. For example, male are more prone to develop acute coronary syndrome as compared to the female. But in the postmenopausal woman, this equation changes, and then male and female, they become equally susceptible to the development of the acute coronary syndrome. As age as one gets older, the risk of developing acute coronary syndrome increases, and those patients who have got a very strong family history of acute coronary syndrome, they are again more prone to develop acute coronary syndrome. When we say strong family history, by that we means that there are a lot of a large number of family members having a heart problem in the early stages of their lives, like around 40 years, 45 years and 55 years. So when at an age of less than 55, many members of the family develop acute coronary syndrome or heart attacks or heart problems, then this puts patients at a higher risk of developing acute coronary syndrome. Then there are certain non-modifiable risk factors. In the modifiable risk factor, these are the one which can be actually changed with effort. For example, a patient can have a better control of the diabetes. Or if a patient is having these risk factors, then patient has got higher chances of developing acute coronary syndrome or heart problem or the atherosclerosis in the coronary arteries. These are diabetes mellitus, hypertension, smoking, being obese, having in or morbid obesity, having higher level of the cholesterol, type A, are a very stressful personality, and sedentary lifestyle. These are the modifiable risk factor, and these are non-modifiable risk factor. Both of these actually put persons at the higher risk of developing acute coronary syndrome or ST elevation MI. So, as we have discussed, the main culprit is the formation of the atheroma in the coronary arteries, which causes ST elevation MI, and it completely occludes the coronary arteries. There are three coronary arteries. One is the right coronary artery. It supplies right side of the heart, right atrium, right ventricle, septum, and 60% of the time it also supplies SA node, which is located in the right atrium. Then there is a left main stem. This left main stem, it subdivides into the left anterior descending artery, which supplies the anterior wall. This is the major portion of the anterior wall. And one is the left circumflex. The name implies that it is on the left side. Circumflex mean it takes an acute turn and goes toward the lateral wall. So left circumflex artery supplies lateral wall, and 40% of the time it also supplies SA node. RCA also have posterior descending artery and right marginal branch. Now there are three walls of the heart, because these coronary artery which we are talking about, that there is a thrombus formation or atherosclerosis in those coronary arteries, and those coronary arteries are supplying certain walls of the heart. There are three walls of the heart, major walls of the heart: anterior wall, and this is a lateral wall, and this is a inferior wall. This lateral wall is supplied by the left circumflex artery. This inferior wall is supplied by the right coronary artery, and anterior wall is supplied by the left anterior descending branch of the left main stem. So heart is like your fist, and it's placed on the diaphragm. It's placed with its inferior wall right on the diaphragm, very a small lateral wall and a large anterior wall. Now another very important factor which we are to remember is that their association of the wall with the ECG leads, and association of the ECG lead and the wall with the coronary artery which supplies that particular wall. For example, making it simple, leads V1 to V6 on the ECG paper, they actually represent anterior wall which is supplied by the left anterior descending artery. So V1 to V6 represent anterior wall. V1 and V2, they are located on the towards the septal side. These are known as anteroseptal. V3, V4, they are located in the middle of the this series, so they are purely anterior chest leads. And V5 to V6 are located towards the lateral side of the anterior wall of the ventricle, so they are known as anterolateral. And lead 2, 3 and AVF on the ECG, they represent inferior wall, and this inferior wall is supplied by the right coronary artery. On the ECG paper, lead 1 and AVL, they represent lateral wall which is supplied by the left circumflex artery. So the intelligent doctors actually know one factor very comfortably, that if they look at an ECG paper and a patient comes with the chest pain and they find certain changes in a particular set of the leads which represents a particular wall which is supplied by a specific artery most of the time, then just by looking at the ECG they can have a better idea that what can be the finding of the angiography. So this is another important factor. Patients have following presentation when they have acute coronary syndrome, especially ST elevation MI. They present with the chest pain on the mostly on the left side of the chest. There is a chest heaviness. There can be either pain in the left arm, or this chest pain on the left side is radiating towards the left arm and the jaw. There can be irritability, restlessness, and very famously we call in Pakistan in our government setups this is known as the ghabrahat. Most of the patients they come, they tell us that they are feeling ghabrahat, and it is irritability and restlessness. So these chest pain, chest heaviness, this can be associated with the sweating, or there can only be sweating because of the sympathetic system over discharge. There can be nausea and vomiting. It can be pain epigastrium. Most of the time when there is a pain epigastrium and nausea and vomiting, and patient has got the risk factor, modifiable and non-modifiable both, or some of them, do get an ECG, because inferior wall MI sometimes presents with this thing, nausea and vomiting and pain epigastrium. I have seen personally so many cases. They've been roaming around to different doctors, and ultimately when ECG was obtained, there was inferior wall MI. Patient can present with a sudden shortness of the breath, and that too I have seen personally, that 2 or 3 cases, they were like at home, or they were in the markets, and all of a sudden they felt chest heaviness for a very brief period of time, and suddenly they went into cardiac failure and developed shortness of the breath. So this is another finding, a clinical presentation. And there, in the elderly especially, there can be extreme sudden weakness. Those patients who are female, diabetic, and elderly, they sometimes have atypical presentation. Atypical presentation includes extreme sudden weakness, shortness of breath, having a feeling of unwellness, and there can be nausea and vomiting. So be very skeptical of the diagnosis. Always try to first rule out cardiac issue, because these issues don't give you much of the time. So better to have your threshold of suspicion of cardiac problem on the lower side, rather than being stubborn that this cannot be heart issue. Always get the ECG, and if you clinically suspect there may be a heart problem, even if the ECG is normal, try to retain the patient for some hours. Repeat the ECG in 30 minutes or 1 hour, and if you are still suspecting that it can be cardiac issue, do get the cardiac enzyme after 4 to 6 hours, because in heart issues most of the time when patients are sent home, they either don't return, or they return in a very bad shape. So always try to be careful while evaluating a patient of cardiac issues. This is always very important to have ECG of these patients. This is a normal ECG. This is P. This is the first downward deflection Q. This is R. This is second downward deflection or negative deflection S. This is T. So this is P, atrial depolarization. This is ventricular depolarization, and this is ventricular repolarization. This is a J point. J point is junctional point where S is actually going to convert into the isoelectric line. But in case of the ST elevation MI, ST segment has gone up. This junctional point has actually pulled not only the S but also the T upward. This is known as the ST segment elevation. Here you can see very clearly that this is a normal ECG and this is ST segment elevation. In itself, this is a sign that you do not need any cardiac enzyme for its confirmation. And whenever you see in ECG leads segments or series that there is an ST elevation, always remember one thing, that particular coronary artery is completely occluded. That is completely occluded, and the muscle it is supplying, the wall it is supplying, is at risk of dying. There is a need of urgency. You need to be very fast. You need to manage patient very fast. This is a 911. This is everything which points towards the red signal. This is a critical state. So this is ST segment and this is a normal. You can well appreciate the difference between the two. There can be a difference in the morphology, but ST segment is going high. These are the ECG changes in these patients. Now, if we actually make an association between the ECG findings, leads in which the ECG finding is present, and the wall, then there is a simple table. Lead 1 and AVL, they are known as contagious leads. If ST elevation is present in lead 1 and AVL, we will call it lateral wall ST elevation MI. Lead 2, 3 and AVF, they are contagious, 3 contagious leads, and at least 2 of these 3 leads should have that change of ST elevation. Then we will call it inferior wall ST elevation MI or inferior wall STEMI. The anterior leads, which are V1 to V6, when there is a change of ST elevation in any 2 of these leads, contagious leads, we call it anterior wall ST elevation MI. But these are subdivided into 3 groups. V1 and V2 are known as anteroseptal leads, and their changes are actually mentioned as anteroseptal STEMI. Why anteroseptal? Because V1 and V2 as the chest leads are located towards the right side of the heart near the septum. V3 and V4 are located in the middle of these 2 groups, and these are known as pure anterior wall leads. And if the change is of ST elevation is present in V3 and V4, we call it anterior wall ST elevation MI. And V5 and V6, as they are located on the lateral side of the anterior wall of the heart in the 5th intercostal space, V5 is located in the anterior axillary line and V6 is located in the middle axillary line, and these are known as anterolateral leads, and change of ST elevation would be known as anterolateral STEMI. But in total, V1 to V6 are known as anterior wall ST elevation MI, anterior wall STEMI. If we look at this ECG, this is a very normal ECG. There is no T-wave inversions or ST depression. If you look at the sets of the ECG leads, lead 1 and AVL, it hasn't got any T-wave inversions or ST depression. So this is lead 1 and this is AVL. So there is no lateral wall ischemia. If you look at 2, 3 and AVF, there is T-wave inversions only in lead 3, but acute coronary syndrome demands that at least 2 of the contagious leads should have any change. So there is no T-wave inversions in lead 2, 3, 2 and AVF. Only in lead T3 it doesn't qualify for the inferior wall acute coronary syndrome. No ST elevation at least. AVR is always a negative lead, and it has got P negative, QRS negative and T wave is negative. If you look at the lead V1 to V6, which represents anterior wall on the ECG, in a normal ECG there is no ST elevation, there is no T wave inversion. If you look at this J point, this is S wave, this is T wave. So junctional point hasn't gone up. In lead V1, V2, you can find a little bit higher T wave because R wave is not that much higher in height. So looking at the V1 to V6, there is no ST elevation, no T wave inversion, so there is no sign of acute coronary syndrome. If we look at this ECG, here we see that there is ST elevation. This is a very clear ST elevation in lead 1 and AVL. Now lead 1 and AVL, they represents the lateral walls. So this is lateral wall ST elevation MI. This patient presented with chest pain, and after his ECG was obtained, there is a J point has gone up and it has pulled T and S along with it. So 1 and AVL have ST elevation. And if you look at lead 3 and lead AVF, there is a very specific ST depression. This is known as reciprocal change. If you can actually understand this concept, the leads which are located opposite to the one which have got ST elevation, they have a reverse change. They would have a opposite change. Rather than having ST elevation, they would be having ST depression. But this is not the primary change. This is the reciprocal change. The primary change is ST elevation, and the reciprocal change is inferior leads 3 and AVF ST depression. So this is primarily lateral wall ST elevation MI. But if you look at the anterior leads, you can appreciate one very important thing, because lead V5 is located on the side of the lateral part of the anterior wall. It also got a little bit ST elevation, but looking at this ECG, you will see 1 and AVL have ST elevation, 2 is okay, 3 and AVF have got ST depression, which are known as reciprocal change. Important to know that this reciprocal change augments the diagnosis of ST elevation MI in the lateral leads. Now looking at V1, V2, V3, V4, V5, V6, other than having this ST going high, there is no specific change. So this is and lateral wall ischemia, lateral wall ST elevation MI, and probably the culprit artery may be left circumflex artery, but this would be diagnosed very properly on the angiography, that which one is the culprit coronary artery. At this ECG, you see that there is also ST elevation, but which leads? Lead 2, lead 3 and lead AVF. They have ST elevation. Lead 1 and AVL have got no specific change, except that lead AVL has ST depression, which is a reciprocal change. So the primary change is ST elevation in inferior leads. Lead 1, V1, V2, which are again reciprocal to lead 2, 3 and AVF, they have ST depression. Or you can also say, because there is a probable culprit artery is right coronary artery, that is the reason that there are certain changes in the lead V1 and V2. Because already there is ST elevation, if it would have not been the case, and these changes V1 and V2 ST depression, it demands that we should have obtained right-sided ECG. But here it is very clear that lead V2, 3 and AVF, they have ST elevation. So this is inferior wall STEMI, and probably the culprit artery is right coronary artery. Even if you look at V5 and V6, they have also a smaller elevation in the ST segment, but not as prominent as that in the inferior lead. Another example of the ECG, where patient presented with the chest heaviness, and when ECG was obtained, if you look very carefully, you will see that there is a very prominent ST elevation in lead V2, V3, V4. And so this is pure anterior wall ST elevation MI. You will find the reciprocal changes in the lead 2, 3 and AVF. There is ST depression, but the primary change of this ECG is ST elevation. So this is known as anterior wall ST elevation MI, and probably the culprit artery seems to be left anterior descending. So whenever a patient comes with the chest pain, you will get the ECG after going through the ABC, airway, breathing and circulation. If you look at lead 1 and AVL, there too you find ST elevation, very prominent ST elevation in lead V2, V3 and V4, and reciprocal changes of ST depression in lead 2, 3 and AVF.